Good evening. My name is Thomas Leist. I welcome you cordially to this year's education series sponsored by the MS program at Thomas Jefferson University. I would be remiss not to recognize the sponsors that have made available funds to make this program series possible for us. The sponsors had no influence on the content of the programs that we are going to present as part of this series. I would also like to thank the sponsors and donors that support important missions at the Multiple Sclerosis Center. One of these functions that is very important, particularly in times as the ones that we just have gone through, is our social worker that is at our center. Please keep in mind that making a social worker available is an important function. So let's look in this segment at how multiple sclerosis is treatment and what our treatment goals are in multiple sclerosis. What I think is very important is to think about changing the trajectory of multiple sclerosis. What I mean by that, I will show you on the next slide. We also need to think about prognostic and radiographic signs, radiologic signs that an individual may bring to the table at the first presentation or during the course of the disease. I would like to emphasize that early treatment matters, but it's not just early treatment, but it's also continuous treatment. And we'll talk a little bit about two different concepts in treatment of multiple sclerosis. So when I talk about changing the trajectory, it is my strong belief that in multiple sclerosis, in individuals that are diagnosed nowadays, where we have options available, that early effective intervention may change the long-term course of that individual. That doesn't mean that we cannot intervene with the condition later on, but I do think that this early intervention, when it is afforded, is very important in individuals. And obviously, this is an area where then also pressure needs to be put on the payers to actually make available effective treatments early in the disease. So what would we like to achieve in multiple sclerosis? The universal goal in multiple sclerosis treatment is to reduce the number of relapses in those with relapsing remitting disease, to slow the progression in both those with relapsing remitting and primary progressive, as well as those with secondary progressive disease, and to change the number of new brain lesions that are acquired. This includes obviously gray matter disease too, and to change how the disease progresses also from a brain point of view, from an atrophy point of view. Obviously, we could say we don't want relapses, we don't want sustained disability progression, we want no new lesions on the brain MRI. These are all very important goals that we would like to achieve, but sometimes they are aspirational. Keep also in mind how we assess relapse in a clinical trial is slightly different from what we do in practice. I may consider a person that has a pure sensory relapse as having a relapse. In a clinical trial, that one wouldn't be counted. What's the course of a person after a first event? And we have now quite a lot of first event trials over the years. These were acquired over almost 20 years. But what you see over here is that in the range about 40% of patients that have 2 or more lesions on their brain MRI at the time of a first event will have a next attack by 2 years. And think about it. A person with multiple sclerosis, a young woman in her early 30s, she has a life expectancy of another 40 or more years. So having a likelihood of, in general, an attack in the next 2 years of almost 40% or so of these individuals having an next attack indicates to you that it is important to intervene effectively and early in the patients with multiple sclerosis. So what are potentially more favorable or less favorable signs that individuals have when they present? Well, attack rate. At the first attack, I don't yet know how many attacks that somebody's going to have. But certainly if there is a short time interval between first or second attack, if there is less than complete recovery, younger onset sometimes means less progressive disease. Women have a slightly more favorable course of the disease than men. And if a person has low disability at 2 and 5 years after onset, and if there are only sensory symptoms but no motor, no strength-related symptoms. All of these are important. We know that we have multiple different agents that intervene with the disease at different levels. So when I think of how the purported mechanism of actions of agents, I think where they intervene. So I don't necessarily think of brand names or of medications. I think of what we think they are doing and which class of medication they belong into. So we have now a very rich treatment landscape in multiple sclerosis that has developed over the last 20 years. And if you think of neurological conditions, it's really multiple sclerosis that stands out with the fact that we can actually start to think of preventing long-term disability and making this condition, multiple sclerosis, in a more manageable disease conditions. So we have the interferons, we have the glatiramer medications, we have monoclonal antibodies and depleting antibodies. All of these are proteins, and proteins cannot be given by mouth because they will be digested. And so from that point of view, these are all medications that are either given by injection or by infusion. Opposed to that, we have medications that are small molecules, and they belong in different categories. We have the modulators, we have the S1P agonist antagonists, and we have the fumaric acid esters. So we have molecules that are small, that are resistant in the stomach, and that can be given orally. We have also in this group anti-metabolites under, for example, cladribine. So this is the reason why they can be given orally. Naturally, we have also treatments that are perhaps more complex, and that's the hematopoietic stem cell transplant, where one does multiple things to treat an individual. We can also think of medications that are available in a different way. These are the medications that need to be regularly dosed. And there are medications that a patient may get only for short periods of time or for pulses. And so there are different approaches. Obviously, the extreme form of this would be hematopoietic stem cell transplant, the autologous stem cell transplant, that would only be given once. None of these treatments at this point in time is curative for multiple sclerosis. All of them help us manage the disease. You say, well, I thought that stem cell transplant fixes MS. Well, it helps to prevent future lesions and disability progression. But even in the best hands, a not insignificant number of patients will have continued disease activity or recurring disease activity. And stem cell transplant does not fix progressive disease, and it does not bring back what is no longer there. So from that point of view, it may help to stop the inflammatory condition, but it is not stopping the progressive part of the condition. And this brings me to what belongs to a management of multiple sclerosis. So we talked about the diagnosis, we talked about treatment of multiple sclerosis, but it also needs to be recognized that management includes the management of symptoms of multiple sclerosis. But these symptoms can be present from very early on, and they may change as the disease progresses. Fatigue is an important thing. Bowel bladder dysfunction are important. Mood disorders are very important also in multiple sclerosis. And obviously, if the disease progresses, certain characteristics of what a patient complains or what a patient's risk factors are also change. And so when I think of MS-associated symptoms, I very often think of a circle where we need to kind of intervene at a level to improve a person's function. For example, fatigue is one of these symptoms. Well, fatigue may have many different components to it. It may be because less exercise, because of spasticity, maybe a bladder problem, get the person up at any time during the night. And it may also be mood related. So from that point of view, when we have a person with multiple sclerosis, we obviously always need to see how we take this circle apart and how we prevent it from overwhelming an individual. And this gives us a roadmap that is unique to an individual person. We need to look at individual aspects. Should we treat depression first? Should we work on energy conversation? You know, sometimes it's more important what you do when you get to a place rather than to spend all your energy getting to a place. And it's also very important to look at other factors, such as, for example, cooling devices, to use all modalities that are available to us. Fatigue is also an important thing because it is not accessible. The only persons that can kind of decide how fatigued they are is the person that is fatigued. And so, in a way, it's one of these hidden symptoms of multiple sclerosis. And here again, we can say maybe our research in the last few years actually allows us to now better understand fatigue and also make it clear that the MS-related fatigue is something that we can start to better understand. And you see this over here out of a study from our colleagues up in Boston that looked at patients that have sustained fatigue versus never fatigue and looked at where there was injury in the brain to the person. And you see where the red dots are. These are the areas where the individuals that had persistent MS-related fatigue were more represented. And so, even though fatigue is a hidden symptom of multiple sclerosis, it is still something that now with MRI techniques we can get much more information about. And so what is very important about this is that it allows us to show that in multiple sclerosis there are changes in the brain that are consistent or going along with fatigue or with a fatigue complaint in an individual. And so from that point of view, while it is frustrating to have a symptom that other people cannot see, it becomes now more and more possible to actually start and to investigate these symptoms and to actually substantiate them with new information. What I have hoped to show you in this relatively 40,000-foot overview of treatment approaches in multiple sclerosis is obviously to show to you that there are different ways of treating the MS, and these individual approaches are significantly important. It is in the discussion between physician and patient that we choose a treatment that is the most appropriate for an individual. It is also very important to recognize that treatment for MS is one part of the management of multiple sclerosis, but there are other aspects, the symptoms that are associated with multiple sclerosis that actually take a significant role in the overall management of multiple sclerosis. And this brings me to the point that really it is very important that a practice that delivers neurological care to MS patients has also helpers around. I view this as the MS point of service. We need to have colleagues from mental health. We need to have colleagues from rehabilitation, from urology. We also need, as I mentioned, social work to help us along, because sometimes MS is a rather unfair disease, and it is very important to bring all modes of treatment and all modes of support to the patient.